Good morning. This is a 20-year-old male who comes in on referral for jaw deformities, discrepancies, and asymmetry. You can see on smiling that his maxilla is poorly positioned. His mandible is over to the left. As you can see as I draw the midline through there, the maxilla is more on with the face. His chin is over to the left as well. On lateral view, you can appreciate this concave profile. The lower lip is more prominent than the upper lip. In excess, there's also some midface and malar hypoplasia and deficiency, and around the nasolabial folds and piriform as well. The intraoral occlusal picture shows a crossbite on both sides that's both relative and absolute. You can see an anterior crossbite that's quite significant, a class 3 molar and canine relationship. The opposite side lateral view shows this concavity again with hollowing under the eyes, the midface, in what's called a negative vector where the anterior cornea is significantly in front of the bone. Here's the traditional lateral cephalogram film where you can see when he's in Frankfurt horizontal to the floor, and you look at a parallel, the 0 meridian line, the mandible is out too far, the maxilla is back too far. It's also vertically up, and there's a significant amount of hypoplasia in this vicinity. There's a class 3 molar and canine relationship again, and this pretty significant anterior crossbite that you can appreciate. Here on a Panorex reformat, very significant class 3 molar on this side, and on this side, midline here to the left, midline more on with the face with the maxilla. So again, we begin with digitizing his existing preoperative CT scan. Prior to surgery with some of these Invisalign cases, we do like at least a bracket or a hook on a few of the teeth to help us with rubber bands. And this just demonstrates what we already know looking at the other imaging and photos. Severe and significant deficiency and depression in this area. The maxilla is back. This is a class 3 molar canine skeletal malposition. Pretty significant anterior crossbite. Not so much true mandibular prognatism, more just midface and maxillary hypoplasia. Here on the frontal view, you can appreciate the same. Here's the midline being on with the face. Here's the midline on the mandible that's over to the left. The chin is also over to the left. Crossbites on both sides. Anterior crossbite, significant deficiency. So in the course of the planning, one of our first steps after setting head position is to look at the occlusion and set the occlusion. So in this case, it was deemed that we needed to segmentalize the maxilla. So you can see this is in 3 pieces. One here, the canine and behind, one for the premaxilla, and one here for the canine and behind. The midlines are set to be on. We try to achieve significant symmetry, both when you look at the proximal rami, the chin, and the rest of the facial bones. Here on lateral view, you can see that improvement. If anything, this is now a class 2 molar, but that's because of orthodontic reasons, and we've given a little excess overjet so that these retroclined mandibular teeth will be brought up. Here we're still deficient, or if anything, there'll be even more deficiency, so this is a case we want to do malar infraorbital implants concurrently, and that's what we'll plan to do in the case. So in this situation, we did mandible first, we did segmental maxilla. Here's the opposite side. We did genioplasty. There's ever so slight setback of the mandible, but this is flattening of the occlusal plane, advancing the maxilla with steepening of the occlusal plane in that vicinity, getting a step or an advancement at the piriform. And this is the amount of segmentation and how and where we're doing it. Again, between the premaxilla, lateral incisor, and canine on both sides, expanding, widening, doing this to help the occlusion as well. And this is the type of palatal splint that we use, placed on the palate as a Hawley splint that stays for a period of time post-op to maintain this new width. So post-operatively, we've seen the surgery now. You can see how there's dramatic improvement. You can see the position of the plates and screws here in the maxilla, 4 of them. This screw is to hold the malar and infraorbital implant on both sides. This is a TAD to help hold elastics, and here's the plates for the mandible for the slight setback and repositioning. The occlusion looks as we hoped and planned, excess overjet, and this will be settling into a nice class 1 molar and canine relationship. Here on the opposite side as well, really filling in this central part of the face, and you can't see because of the lack of radio opacity, but there's a malar medpore type implant in this vicinity. Here's on the more traditional cephalogram where you can see the radiograph before and after. And now, importantly, looking at his face and facial symmetry. So this is filled in nicely because of the implants. This is filled in nicely because of the Lefort osteotomy. It can at times have a effect on the nose where you can see the alar base is widened. You can see his mouth width is a bit widened, but his lower lip has come back some. His upper lip has protruded some, and his chin is much, much more in the center now, and his symmetry is really quite good. On lateral view as well, you can see this is nice and filled in to some extent from the implants and fat grafting. This is nice and filled in. This is a more normal contour compared to the other side. The lips now have the appropriate E-line and S-plane type of relationship. And compared to the 0 meridian line, everything lines up quite excellently. Here's the opposite side again. Excellent profile. And this puts it together on the 3D rotating view before and after. And this comes about again because of double jaw surgery with segmentation of the maxilla, BSSO, Genioplasty, fat grafting, malar, and infraorbital implants. So thanks for listening. If you have any other questions, please check us out on our website, www.dereksteinbacher.com. Thanks again.